In this film, internal maneuvers performed for a shoulder dystocia will be demonstrated. The maneuvers are shown in order from less to more invasive for mother and baby. In the event of shoulder dystocia, prior to performing internal maneuvers, external maneuvers may be performed in an attempt to resolve the shoulder dystocia. For a more detailed elaboration of this, refer to the course Shoulder Dystocia External Maneuvers. The maneuvers that have to be performed will be shown on a model and are alternated with images of a second baby doll placed on the mother's abdomen, on which the same maneuvers will be performed. In this way, insight will be provided into what happens internally whilst performing the maneuver. Shoulder dystocia occurs during childbirth when the anterior shoulder of the fetus, seen here, becomes impacted behind the symphysis of the mother. Take note that during labour, a slow progress in dilatation or expulsion of the baby, head bobbing, and turtle sign might indicate a shoulder dystocia. With head bobbing, a jerking movement of the fetal head is seen as the head appears and retracts during each push. When there is a turtle sign, the head may be only delivered partially or suddenly retract back against the mother's perineum after it is born. In case the head of the baby is not delivered completely, the caregiver may assist by placing the thumb and index finger on the perineum of the mother and slide it off over the head of the baby while looking at the perineum of the mother. Emptying the bladder of the mother with a catheter may be considered to create more space in the pelvis if a shoulder dystocia is expected. This may not always be performed. After the birth of the head, the neck is palpated with 2 fingers to check whether the umbilical cord is wrapped around the neck. Take note that if the fetal neck is tightly encircled by the umbilical cord and it cannot be freed without cutting the cord, the umbilical cord is cut only after the shoulder dystocia is resolved to prevent oxygen deprivation. For a more detailed elaboration of the management of the nuchal cord, refer to the course Management of the Nuchal Cord. During a normal delivery, when the fetal head is born, an external rotation of the head of about 90 degrees is visible due to the internal rotation of the shoulders. If there is no spontaneous rotation of the neonatal head, the mother is encouraged to push to see if a rotation takes place. If rotation does not take place, the head is grasped with the fingers of both hands, interlocking over the occiput of the fetal head, and continuous downward traction is applied on the head towards the sacrum of the mother. In an alternative technique, the index and middle finger of the dominant hand are placed on both sides of the fetal neck. The non-dominant hand is placed on top. Then continuous downward traction is applied towards the sacrum of the mother. Take care not to put too much traction on the head in a downward direction. The head should also not be rocked from side to side. This may lead to irreversible injury to the brachial plexus of the baby and should be avoided in all births. Also take care not to apply fundal pressure in an attempt to resolve the shoulder dystocia, since this is associated with a high neonatal complication rate and could cause a uterine rupture. If the aforementioned techniques are unsuccessful, it is advised to call for additional help if available, since this is now a complicated delivery. Additional maneuvers to free the shoulders will need to be performed. In this film, the internal maneuvers will be shown. For a detailed elaboration of external maneuvers, refer to the course Shoulder Dystocia External Maneuvers. To allow for easier access to the vagina, the end of the bed is removed. Take note that if only a normal bed is available, the mother may be rotated 90 degrees in order to achieve the same effect. Take note that the buttocks of the mother are right at the edge of the bed. Take note that an episiotomy will not resolve the shoulder dystocia directly, but may be required to allow the healthcare professional more space to facilitate internal vaginal maneuvers. For the Rubens maneuver, the index and middle finger of the dominant hand are inserted into the vagina and placed on the scapula of the anterior shoulder of the fetus, which is positioned under the maternal symphysis pubis. Pressure is then applied in an attempt to rotate the shoulders into the 3 and 9 o'clock position. Take note that this, the transverse diameter, is the widest diameter of the pelvic inlet. If the shoulder is not released by using the Rubens maneuver, the Woods maneuver may be performed. In the Woods maneuver, the index and middle finger of the dominant hand are inserted into the vagina and placed on the scapula of the anterior shoulder. The index and middle finger of the non-dominant hand are inserted and placed on the clavicle of the posterior shoulder, which is positioned at the maternal sacrum. Pressure is then applied in an attempt to rotate the shoulders into the 3 and 9 o'clock position. Take note once again of the placement of the index and middle finger of the dominant hand on the scapula of the anterior shoulder, and the placement of the index and middle finger of the non-dominant hand on the clavicle of the posterior shoulder. If the Rubens and Woods maneuvers are unsuccessful, extraction of the posterior arm may be attempted. To extract the posterior arm of the fetus, the caregiver's hand that is positioned on the side of the fetal abdomen is inserted into the vagina at the abdominal side of the fetus. The fingers follow the humerus up to the elbow and flex the arm by applying pressure to the cubital fossa. After flexing the arm, the forearm is grasped and pulled outside past the thorax and the face. Note once again that an episiotomy will not resolve the shoulder dystocia directly, but may be required to allow the healthcare professional more space to facilitate internal vaginal maneuvers. If the aforementioned techniques are unsuccessful, the mother may be turned from a supine position to all fours, a position on the hands and knees. Now the on all fours position is shown. As mentioned earlier, this position may be turned to before using the internal maneuvers or after, as is shown in this film. By turning to all fours, the anterior shoulder often dislodges spontaneously. Take note that in the all fours position, more space is created around the posterior shoulder due to gravity pulling the fetus anteriorly. Therefore, without performing any further invasive maneuvers, the fetus is first mildly bent towards the symphysis of the mother to see whether the posterior shoulder is freed. If the shoulders are not released by turning to an all fours position, all the previously shown internal maneuvers may be performed again. Here, the Rubens maneuver is seen in the all fours position. The index and middle finger of the dominant hand are inserted into the vagina and placed on the scapula of the anterior shoulder. Pressure is then applied in an attempt to rotate the shoulders into the 3 and 9 o'clock position. Take note that the fetal back is now on the contralateral side due to the rotation of the mother onto all fours. Here, the Woods maneuver is seen in the all fours position. The fingers are placed on the scapula of the anterior and the front of the posterior shoulder. Then, pressure is applied in an attempt to rotate the shoulders into the 3 and 9 o'clock position. If the Rubins and Woods maneuvers are unsuccessful, extraction of the posterior arm may be attempted. To extract the posterior arm of the fetus, the hand that is on the side of the fetal abdomen is inserted into the vagina. The fingers follow the humerus up to the elbow and flex the arm and pull it outside past the thorax and the face. If all the previously mentioned maneuvers are unsuccessful, one of the following procedures may be performed. Fracturing the clavicle to decrease the shoulder-to-shoulder distance. Symphysiotomy to increase the width of the birth canal. And the Zavanelli method, in which the fetal head is pushed back into the pelvis, after which a caesarean section is performed. These are all highly invasive techniques and should preferably be performed by healthcare professionals experienced in them.